and I work here in the Public Health Division and Director's Office, and I've been one of several people in the building helping to plan this week's event. So thank you so much for joining us today, and thanks for people who are joining us on the live stream. Before we begin, I just want to provide a few quick announcements about Public Health Week. So for those of you with a competitive nature, if you work here in the division, we have a little passport to prizes game. So if you're playing along, you can just, I'll sign off that you're here, and then you can turn it in. There's a box on the table by the display board in the lobby, and then you can win free lunches and lots of fun stuff at the end of the week. Second, there's a week-long scavenger hunt, health equity themed scavenger hunt going on in the building. It's being put on by one of our student interns from De La Salle, so there's more information about that coming in the daily emails. So I encourage you to grab a few colleagues and play along, take the stairs, get some exercise. There's also an opportunity to take part in a recorded audio conversation about health equity, so this is similar to NPR's StoryCorps, if any of you are fans. So this is being put together by Jasmine Griggs and Julie C. Fuentes in the building. So if you are interested, look for more information in the daily emails. Contact them directly to set up a time to have a conversation or interview someone that you want to chat with. And finally, for those of you who are into social media, we are launching a new hashtag this week. That's hashtag This Is Public Health OR. So if you are tweeting or doing any of those things, we encourage you to use that hashtag and give a shout out.
Say that again.
It's like pound.
Okay.
This is Public Health OR.
Okay.
So just a great way to celebrate and communicate with the general public what we do in public health and what we talk about. We will also be sending out an online evaluation early next week. So for those of you who work in the division, we encourage you to look for that. Take a look, let us know what you think. The feedback that we got from last year's event was really helpful in putting this week together, so thank you for your feedback. And finally, thanks for being here, for celebrating public health and supporting colleagues and partners that have joined us today, and demonstrating your commitment to advancing health equity. So I am really personally very excited about this event and the great people who joined us, so I'm going to turn it over to Jude Leahy from Public Health Division.
Hi. So I'm actually going to read, since I get nervous when there's like a camera. So, so welcome to our workshop this afternoon, and a special welcome and thank you to those who are joining us over the internet. My name is Jude Leahy, and I did write that down. And I am the Oregon Viral Hepatitis Prevention Coordinator, and I work in the Acute and Communicable Disease section in the Public Health Division here. I would like to go over the agenda for our workshop so that those joining us over the web are able to watch the documentary using the link and then join us for a follow-up panel question, answer, and discussion. We are discussing safe consumption spaces. These are spaces where people can go to consume, meaning inject or smoke or any other way, use drugs that are obtained elsewhere in a safe, clean, under safe, clean conditions and under the supervision of trained staff. The documentary and the panelists, the amazing expert panelists we have here, are going to provide a lot more detail about this in a few minutes. So for our agenda, particularly for people on the internet, we are going to, at the latest, start the movie here at 2:25. It's 35 minutes. It was 34 minutes long. So we'll be done by 3 o'clock, and then we assume at 3 o'clock we are going to do question and answer with the panelists. The goal of our workshop today is to increase understanding of the systematic barriers that people who use drugs face and the health consequences related to drug use, with a focused discussion on the consequences of drug use in public spaces. We hope to increase your awareness of safe consumption spaces and their role along the continuum of harm reduction interventions, and then also increase our understanding of how safe consumption spaces can reach and maintain contact with hard-to-reach, extremely vulnerable, and highly stigmatized populations, and promote the health of this population by providing sterile and clean injection equipment, reducing drug-related risk behavior, including overdose and non-sterile injection practices through the provision of tools and education at these sites, reduce the incidence of infectious diseases related to injection drug use, including HIV, hepatitis C, bacteremia and sepsis, endocarditis, osteomyelitis, and other types of bacterial and fungal infections. Also facilitate the access to health, psychosocial, detox, and substance abuse programs. And then also, I think most importantly, provide a non-judgmental space where people who use drugs are treated with respect and dignity. And now I'm going to allow the people on the panel to introduce themselves in any way they feel called.
My name is Dan Epting. I identify as an addict in recovery or former drug user or however. I work in the substance use disorder services field as a peer support specialist, and I've been in recovery for coming up on 10 years. That's me.
Thank you.
Back.
I'm Haven Wheelock. I am a longtime harm reductionist. I've been working with people who use drugs since 2002, specifically here in Oregon for the last 11 years, and drug users are my favorite people in the entire world. Just gotta throw that in there. I also am an MPH fellow at Johns Hopkins, working under the Bloomberg Initiative for Overdose and Addiction.
Thank you for being here. I'm Ilona. I'm a nurse in adult acute care and a volunteer in harm reduction services working with syringe exchanges around town. And I also love drug users.
I'm Martina. I've been working in drug user health on and off in different capacities for about 6 years, I think. So back in Australia at a primary health clinic specifically for people who inject drugs, and in Portland more around HIV and Hep C prevention. Been trying to push through some rapid Hep C testing programs in the couple of programs, and now I'm in Hep C treatment.
So I wanted to say a little bit about substance use and infectious disease before we start. So substance use disorders are now recognized as chronic, relapsing medical conditions. However, people living with substance use disorders still experience significant stigma. According to SAMHSA, which is the Substance Abuse Mental Health Service Association, for people with substance use disorders, stigma disproportionately influences their health outcomes and their mental well-being. The fear of being judged and or discriminated against prevents people with substance use disorders from seeking and getting the help that they need. And stigma also prevents caregivers and others in positions to help from providing the needed services, including medical care. Serious and costly acute and chronic diseases and health issues are linked with substance use disorders, and there are elevated risks associated with specific drugs such as methamphetamines, benzodiazepine, and opioids, and with certain routes of transmission such as injections. In Oregon, we are experiencing an increase in newly reported cases of hepatitis C among people under 35 years of age, and these cases were more likely to be recently acquired through risk behaviors or exposures that include shared injection equipment, including needles. Over the past decade, Oregon has experienced an increase in the number and rate of persons diagnosed with opioid use disorder, and similar to other states, over the past decade, we have also experienced an increase in heroin-related overdose deaths. Recent research has found that sharp increases in infectious endocarditis, for example, can be early warning signs of new or emerging pockets of injection drug use, especially in areas where injection drug use has not been previously an established problem. Persons who inject drugs commonly experience infections such as abscesses, cellulitis, chronic wounds, which can lead to hospitalizations for more severe skin and soft tissue infections, bacteremia or sepsis, osteomyelitis, and infectious endocarditis. From 2008 to 2015, Oregon observed more than a 5-fold increase in the percentage of inpatient hospital visits among people who inject drugs for these types of infections. And so we are here today to talk about safe consumption spaces, and I believe Haven's going to talk a little bit about harm reduction before we start.
Sure, I can do that. So how many people are familiar with the term harm reduction, just to kind of get a sense of who's in the room? Okay, so harm reduction is a broad framework of working with folks who, it's actually a term that has been around for a long time. It's the idea that people are going to do harmful things all the time. We do them anyone who's crossed the street or gotten in a car has done something inherently dangerous today. However, we do things to mitigate those harms. The term came around out, Peter, you're making me nervous. Yeah, you are, you're just so smart. So the term originally came around HIV, and it was identified in the 80s that HIV was a thing. Injection drug use was a risk factor for HIV. HIV was transmitted through sharing syringes. And so back in the old days, when we talked about harm reduction, it was really specific to injection drug users who, as a way to prevent the spread of HIV. That kind of progressed once we identified that Hep C was also a thing, and not just hepatitis A, not B. It included some of that. Today, harm reduction is a term that's used in many, many, many different ways about many, many, many different health outcomes. And here, and in the work that I do, it's really still focused on people who inject drugs, because I think they're my favorite people in the whole wide world. But we actually spend a lot of time talking about all these other risk factors associated with it. And it's really been driven by the concerns of the community. So I spend way more time talking about overdose than I do hepatitis C or HIV. I spend exponentially more time talking about hepatitis than HIV, because it's a bigger issue for the community. And really it's like a set of tools and strategies to help people improve their health in whatever way feels best for them at that moment. And it's also an idea that if you can engage people and you can build those therapeutic relationships, you can help nudge them into healthier behaviors. So often people use the term meeting people where they're at when they talk about harm reduction. I don't think that's enough, because I don't think that's actually what we do. We're meeting them where they're at and either standing with them there with dignity or helping them move forward. And all of that is really important. And so here in the Portland metro area, we have three really amazing harm reduction service providers, Multnomah County Outside In and Portland People's Outreach Project, all kind of engaging in different ways and different scopes. And harm reduction is part of the continuum of care for people who use drugs. I think often it's like harm reduction gets pitted against drug treatment in a way that isn't really appropriate, right? If we understand that addiction is a chronic relapsing condition, right? If it is either you are in treatment or you're not, what happens to those people who relapse, right? If we know that it's a thing. And so harm reduction services are on that continuum, and people can move back and forth throughout that continuum, much as people can move through finding out they have HIV and then being on meds for a while and then not being on meds. Like, those are all things that we are really kind of comfortable hearing. People who have diabetes can be stable on their insulin for a while, and then something changes and they struggle to get back. And so we provide services for people who are on this end of the spectrum, right? The side that they're still using, and they may or may not want to stop using, and that's okay.
I was gonna say,
I
when
miss
I was
something?
preparing for this, I was looking through my notes, and I had a note of something that Haven said on a call that we were on, and I think, and I'm gonna quoting you, harm reduction focuses on the prevention of harm, not the prevention of drug use.
Mhm.
So that you meet people where you're at and you stand with them.
Yeah.
Mhm.
Sweet.
How are we doing on time?
It's 2:17.
Okay.
Do people have questions specifically around harm reduction? We're a small enough group, I feel fine asking questions in the middle of this, so. Yeah,
That was prevention of harm versus reduction and
prevention of drug use.
thank you.
I don't remember saying that.
Yeah, I do. I just wrote up meeting notes. So.
Okay.
Not this last meeting, but a meeting
Yeah.
in February.
And I mean, I think it's important when we think about people who use drugs, right? We so often, especially in like places like the public health division or a healthcare setting, we're so quick to silo these individual humans into disease states, right? Like the viral hepatitis people, how often do you meet with the HIV people? How often do you meet with the, addictions folks, the PDMT folks? And
as someone who gets invited to all of those meetings, like,
It's dehumanizing.
it's really dehumanizing. Yeah, right? And it's like, and drug use is a mitigating factor in all of those things. And so I think one of the things that harm reduction does, in a way that I actually don't really see happening pretty much anywhere, is really keeping, it's not about the disease state or the infection. It's about the human being sitting in front of you, right? Like if I have a client sitting in front of me with a soft tissue infection, it might not be the right time for me to talk to him about his hepatitis, right? Like, although it's really important, like that soft tissue infection is gonna kill him faster than the hepatitis will, right? And if he's not gonna go to the doctor for the soft tissue infection, but he's gonna go use over on the freeway overpass, maybe I should make sure he has naloxone, right? That he's using with someone else, because an overdose will kill him faster than the soft tissue infection, faster than the hepatitis, right? And so kind of talking to people about what they need and want, and I think by giving people that voice, it's really helpful. Did I miss anything, you guys, in the basic definition of harm reduction?
I might add,
Yeah.
if you don't mind, in addition to looking at the individual and really being present with that person, acknowledging the context that people use within is something that really stands out to me about harm reduction. Recognizing that like people aren't disconnected from their surroundings, that like people use for all kinds of reasons, and some of those reasons are working for them. I've met an uncountable number of people who attribute their survival and their ability to like move forward in the world to the drugs that they're using. And if it means that somebody can survive what is happening in their lives, like dead people can't make changes. I feel like that's come up in conversations that we've had. And every life is important. And if we fail to recognize the reasons that people come to drug use and potentially come to substance use as a disorder, which I think is often kind of lumped together, that not everybody that uses drugs would meet the criteria for a substance use disorder. But for those that do, I think that meeting those folks with compassion and support, whether their drug use is working for them or not, and recognizing that that's a dynamic thing that is very situational, is one of like the most profound lessons that working in harm reduction has offered to me.
I think respecting people's agency. I think often when people see people that use drugs, they imagine some kind of zombie scenario where people don't have their cognitive faculties about them, and then it ends up being like this whole patronizing, paternalistic kind of interaction. So yeah, for me, harm reduction is very much about respecting people's agency, and yeah.
And I was going to say before, I only made 10 copies, but one of the things I think that's really important, I think when we talk about harm reduction and just listening to you guys talk, is just about it's people first. And I think we have so many labels that we put on people who are using drugs that keep them from either wanting to actually talk with us about what's going on or believe that they're even worthy of seeking help.
I feel like I'm the only one who hasn't said anything. I guess it's because I am. I mean, everything is harm reduction, really. I work in a medication-supported recovery program. We do treatment with Suboxone and Vivitrol to work with opioid replacement therapy. I see people come in that are absolutely broken and beaten. People nobody believes in them. You know, and as a society, I mean, we see on the news the opioid crisis, and that's what it is. It's the opioid crisis. It's this big thing. It's this big title, the opioid crisis. But until you get your hands dirty and you get down in it, that's all it is, really. I mean, it's just a blurb that you hear over and over and over, like terror, right? It's just, it's shock value, the opioid crisis. Until you get down and you get dirty, you don't really have any idea. You know, I used heroin intravenously for, you know, probably 18 years, and I didn't start with that, you know. I mean, that was the end of the road. It was like, whoa, hey, here we go, this is the one. I found opiates, and it was like being hugged by Jesus. I don't know how else to put it. It was just so warm and comfortable and safe, and the best thing ever. And I was willing to put everything aside in the world to keep that up. And I think, like, you know, we need to really understand that, like, addicts, whatever it is, whatever substance you're using, they're human beings. You know, with dreams and goals and wants and needs. And I was talking to Ilona, and somebody said, I saw somewhere recently that, you know, that, like, it was a nurse that said, you know, if addicts could, they wouldn't be addicts. And maybe that's true. Like, you know, right there in the moment when you're going through that shit, it's miserable. You know, it's horrible. But looking back, 10 years back, I wouldn't change a thing. And that might sound crazy, but, you know, the nights in prison, the nights literally in the penitentiary, the nights homeless, the days waiting in the cold and the pouring rain on the corner for the Connect to pull up, and him being 45 minutes late and me having to swallow that shit, pardon me, I wouldn't change any of it. I wouldn't, because it's who I am today. And that addiction doesn't define me. And so, you know, harm reduction, somebody may not be ready to just stop right now. You know, they may not be ready, you know, and who are we to tell them that they have to? But we should allow them to feel like human beings that matter and have a purpose on this earth. Just because you use drugs doesn't make you some inhuman, vile, disgusting beast. And I feel like society, you know, a vast portion of it, that's how they look at people. You know, think about, I don't know, I'm good.
I can listen to him talk.
Okay. So I think, so what we're gonna do, so Britt, are you gonna put up the link?
Yep.
Okay, so there's gonna be a link on the internet so people can go watch the movie, and we will be back in approximately 34 minutes.
Okay.
30.
People cried.
Alright, we're gonna start with some questions?
Sure.
Okay, so we'll start with you, Haven. So the film is a couple of years old now. What are some of the changes that you've seen since this film was made?
So this film was actually, just a little background on this, this film was made by two of my really good friends who at the time were working in harm reduction services, one at Vocal and one at Washington Heights Corner Project. And they came together to make this film. I think it was 2013, 2014 this film was made. And, you know, they really, I think this film is really good. One thing I find incredibly striking, there was one word that when we talk about opiate overdose and the overdose crisis right now, there's one word that is really common today that was not once mentioned in this film. Did anyone else pick that up?
Opioid?
Nope.
Oh, well, you said that wasn't mentioned?
Uh-huh. They never once said the word fentanyl. Right? And so that actually gives me goosebumps to say it out loud, actually. When we talk about those numbers and the increases in those numbers and the numbers that they mentioned here, all of that is pre-fentanyl. And for folks that don't know, fentanyl is a really powerful synthetic opiate that's being sometimes cut into drug supplies, sometimes being sold on its own and being used by folks. It is a series of analogs of pharmaceutical grade fentanyl. It is not part of like doctors misprescribing fentanyl. This is stuff that is being bought on the black market and used in that way. And it has dramatically increased overdose death rates. Mostly so far, knock on wood, on the East Coast and Midwest. We haven't seen a lot of it here yet. However, that is changing. We're seeing more of it locally than we have before. And I feel like it's only gonna get worse. And so, you know, in talking about how important it is to be talking about these things, like we actually are in a good spot to prevent, like this is going to get worse and overdoses are going to get worse as we see more fentanyl in our drug market. There's just, that's what, and I don't mean to be like critical or like fear tactic based on this at all, but this is what I watched my friends on the East Coast live through, right? I have friends all over luckily the harm reduction community is small and tight and we love each other a lot, which is great. But that means I do have friends who are working in Vancouver, BC right now where, you know, it's just, people are just dying left and right. I have friends who've lost, this year I personally lost at least one client every week that I personally knew. That's not the same as the numbers. These are people that I hug that are no longer with us, whether it's from hepatitis or skin infections or accidents or overdose, wide range of things happening. And so these numbers and these projections are things like, that's them pre-fentanyl, it's all bigger now. I think the other thing that, that was the biggest takeaway from this film is that piece, but I also think it's really awesome and hopeful. So they said in the film that there were, 60 safe consumption spaces operating? 98?
98.
Okay, sorry. 98 safe, so when this film was
In
made.
66 countries, in 66
Cities.
Cities, yes.
Cities. So that number is now almost 200. So
Is Vancouver still the only city in North America?
that is not true anymore. Vancouver now has 4 operating safe consumption spaces in Vancouver. There's one in Toronto and Edmonton? Ontario, maybe? I'd have to look. They've opened many sites in the last year and a half to address the fentanyl crisis. There are currently none legally operating in the United States, although there are several cities that have said they are going to move forward with them. So a year and a half ago, Seattle said and funded for 2 safe consumption spaces in King County. A couple months ago at this point, San Francisco said they were going to shoot to open 7 in San Francisco, and Philadelphia is the most recent to come out and say that they are going to open. None of them have actually opened. There is a illegal underground site operating somewhere in the United States that has been reported in the literature and has been being followed for almost 3 years now. It's the Somewhere paper. So they've actually published 2 papers on this site that's been running underground. The cool thing about that is a lot of the concerns people have about safe consumption spaces, that it's gonna bring crime and everything's gonna go. If this site has been able to run undetected in a neighborhood for 3 years, that says something about this fear that could come if we opened a site, right? So I'm sure, and I definitely know there are other places, there are many like harm reduction programs like shown here that people know are using. Drug users do an amazing and wonderful job of taking care of each other. It's a wonderful, beautiful community of people. Hell, today I took my 1,700 overdose reversal report since we started handing out naloxone, right? 99% of those overdose reversals were drug users saving other drug users. It is a tight-knit community that is beautiful and cares about each other. And so I'm sure there are places, homes, where people are letting people use in them and like taking care of each other in that way. But there's none that are open without a network.
Sanctioned.
Yeah, okay. They're still risking arrest.
Right.
Did that answer your question?
Yeah.
Okay.
So the film had a lot of personal stories told. And I wanted to ask you, Dan, how your story relates to the film in like the differences in time and location and just the differences in your personal experience.
I was on the West Coast here, Portland and Los Angeles. Narcan wasn't available really when I was actively using. It was different, and a safe injection space was like a bathroom with a lock, right? I mean, that was really, that was it. Like Starbucks were really good because they were clean and they had locking bathrooms. They were my favorite, just keeping it real. Narcan was not available, and I remember going out, we're at the Oregon Health Authority, what is that, the Doubletree, right there? Oh yeah, in that bathroom. Coming to, in that bathroom, with my works and my spoon on the toilet paper right there. To an employee, hey, I was like, oh my fucking God, I've gotta go. Pardon my language. And that's terrifying. Are they gonna call the cops? What's gonna happen? Here's the deal, I was an addict. I was actively using heroin. If I didn't have it, in the beginning, I didn't necessarily plan on getting a habit. Once I did it for a while, I had one, and if I didn't have it, I got sick. I didn't necessarily know how to function in life without heroin. I became criminally dependent so the two addictions, the criminality and the chemicals, they fed off one another, and it was a vicious cycle, and the fear of change was huge. We used to, at least I can speak for myself, on multiple occasions, I carried friends in a fireman's carry to a payphone where I called 911 and waited for the sound of the ambulance getting within a couple of blocks before I left, because when the police showed up, they were going to ask me to empty my pockets and for some ID. That was the world that I lived in, and I look at myself as a good dope fiend because I would do that. I wasn't gonna leave you, but I definitely got high with people that were like, man, that's his problem. She went out, that's her fault. I couldn't, whatever. That just didn't work for me as a human being. That wasn't a level that I ever went to, and hopefully a level I'll never go to. It's different now, it is, the game changes. The good thing is there is naloxone. And amazing people are training people and passing it out on a daily basis. In the program that I work in, I'm a certified naloxone trainer, and every new client that we have, I do a quick naloxone training, and within a few days, I give them 2 doses of nasal naloxone. I get to do that, right? I get to do that. I get to do all this stuff today. I get to suit up and show up and be an advocate and an ally and everything else for my peeps, because those are my peeps out there, really. Fentanyl is terrifying. That's terrifying, and I keep waiting, for it, like the other foot to drop, for it to really start making an appearance here in Portland. They have test kits. This is harm reduction. They have test kits that you can take your dope in and test it right there on the spot for a little inexpensive test kit to see if it has fentanyl in it, right? we should be making this available, because no matter what, people are going to use drugs. They have. As long as time has existed and there has been human beings, people have used drugs, you know? And if you look in the animal world, animals use drugs, right? I mean, all creatures do for certain things, you know? Everybody wants relief from the horrible economy or the political climate or the lack of housing or the loss of a job or a loved one. And like, what are the things that we turn to? Drugs and alcohol are definitely high on the list. So that's never going to stop. It's not, you know, it's just not. I mean, you can try and run all the lame wars on drugs, you know, that just destroy families and communities, and it's never going to stop. And the longer we criminalize it, you know, the more the cartels and the private prisons, and okay, so, you know, I'm kind of going off on a tangent, but it's there, you know? The more fathers we take away from their children, the more communities that we destroy with this, it's ridiculous, you know, at some point in time, like, we need to move forward and practice some acceptance and realize that this is the way it is. And so how do we help these people? How do we help me? How do we help your son or your nephew or your mother? How do we help them and make them feel human and safe? Because when that happens, that's when people might, just like they were saying, be vulnerable enough to say, you know what, I really don't want to do this anymore. Let's take a look at my options, right? I think, is that good?
That's great. All right, I've got a question for you too, Ilona. So they mentioned they did a good job of showing the sort of environments where people shoot up, and they talked a little bit about the injuries that people get. So I was wondering what you're seeing in the hospital setting in terms of people coming in with injuries due to using drugs in public spaces.
Yeah. I find that I'm very grateful for my position because I have a foot in the community and a foot in the hospital. And I get to know people when they're not as sick, and then I get to know people when they're very sick. And we see complications of intravenous drug use regularly as a part of our inpatient population. And there's a lot of unnecessary suffering that I think we could prevent by having safe places for people to go. And in the absence of those places, I think Dan touched a little bit, and the video speaks to a number of sort of contributing factors. But without the information and the supplies that people need to inject the drugs that they're using more safely, we see infections like bacteremia, a bacterial infection of the blood, endocarditis, which is when the bacteria infects the valves of the heart, sometimes resulting in the need for a valve or heart transplant. We also see a lot of soft tissue infections and bone infections, cellulitis and osteomyelitis. And for many of these conditions, the treatment that's indicated is a 4 to 6 week course of intravenous antibiotics. And for a variety of reasons, this is very challenging. It's challenging for the patients, like for any patient, to ask somebody to be in the hospital for 4 to 6 weeks is very hard, right? But if you add to that the repeated cycles of trauma, both physical trauma, experiencing withdrawal, psychological trauma, experiencing withdrawal every day for the first several weeks of this course of treatment, on top of being acutely ill. I think that paired with the force of stigma that people often face interacting with the medical system. And I will say, there are some very lovely people who are working really hard at improving some of the systems issues in the hospital. That aside, I think that people have understandable reluctancies, and with limited access to healthcare resources outside of the hospital, we find that people are presenting, there's a delayed presentation. So when people come to us, they're very sick. And the challenges that come with a 4 to 6 week course of IV antibiotics are then exacerbated because either they're not able to get placed in a facility that is outside of the hospital, oftentimes because they are drug users, because they are people who use drugs, facilities will deny them placement, which is a whole issue I can barely even begin to get into. And it's a hard place to be. And I think that's true for everyone, and especially for people who use drugs. So for some, that means leaving against medical advice. And this is heartbreaking to me because it means that the concern that brought them into the hospital is not resolved. That also means that they will likely get sick again because their infection has not been cured, let's say. This has broader implications for what we have come to understand about incomplete courses of antibiotics and the way that that contributes to antibiotic resistance, I think is something that is worthy of further consideration. And I think that there's obvious financial implications, which if the human argument isn't strong enough, the cost of somebody attaining a 4 to 6 week course of inpatient antibiotics is pretty astounding. When you add to that repeat admissions because their course wasn't completed, their infection was not resolved, I think the numbers are striking. And I think we were talking earlier about how we're looking upwards of $200 million just in the costs related to admissions due to complications of intravenous drug use in 1 year alone. And this is a couple of years ago, and we're seeing those rates increase. And the fact that all of these complications could be prevented by having a space where people can go to learn about strategies for reducing the risks of injection drug use, to have the tools that people need to inject their drugs more safely, and of course to come and hang out with us and to meet each other, to have the power of peers who, especially when they're equipped with the knowledge and the skills, the power of peers passing what they understand onto each other, which is going to happen anyway, especially in a tight-knit community, I think is can't be understated. So we see people who are very, very sick and have an immense level of suffering that is hard to watch, and I think that all of this is avoidable. If not all of it, then so much of it. And there's work to be done at the systems level in all of our hospitals, and the way that that bridges to the work that we can do in preventative healthcare services is made so clear in a consumption facility where people can come and access the things that they need to avoid these things. Which are, it's not only suffering, people are dying.
Next question for you, Haven.
Okay.
So as Alona beautifully described, safe consumption sites are a brilliant preventative measure that prevents infections, like a whole host of health problems, prevents death, and it just saves money in a whole range of areas. Considering that, why don't we see more safe consumption sites, and what are the biggest barriers that we face in Portland to setting one up?
So, being very thoughtful right now because I want to rant really loud and be really excited. You know, I think we have 100 years of treating people who use drugs as criminals, right? We have this war on drug users. It's not a war on drugs, it is a war on drug users. We have a war on drug users that was designed to put Black and brown people in prison. It was designed to lock people away and disenfranchise them, which is the exact opposite of what we know works to help people who use drugs. And it's slow to shift that mentality. I think society as a whole is shifting in some of its thinking around drug use, in part because of racism. The fact that the opiate crisis we are looking at today is the white faces involved in that have brought a lot of more political will and political acceptance than the Black and brown faces that were associated with the crack epidemic.
And empathy.
And empathy, exactly. And so I think it's important to say that. That being said, drug users are treated like shit everywhere they go. And as policies go, like, yes, there was a time, I mean, Jude probably remembers a time where you couldn't use the term harm reduction in this building.
I don't know about this building, because I didn't come here from San Francisco, but yeah, there was a time where we couldn't use the word harm reduction in CDC language, and I think there was another time we couldn't say that condoms prevented HIV. So.
Right.
And
So
the time that's returned.
some places.
Some places, maybe.
No, in CDC, in federal
Yeah.
government.
Yeah.
Yeah.
So, I mean, I think I think a lot of it has to do with political will, right? Like Dan was saying earlier, we talk about the opiate epidemic and the opiate crisis, but we're not funding it like it's a crisis at all. Not on a state, local, federal level, it's not getting funded as a crisis. It's not being organized like a crisis. If we wanted to acknowledge that this was an opiate crisis, we would be pulling together weekly meetings of all of the factions, right? You wouldn't have, if it was an actual crisis, the substance use people would definitely be talking to the hepatitis C people, right? And so there's I think there's a lack of will to actually address this. I think that it's much easier to write policies for doctors to control their prescribing protocols or require them to be on the PDMP. It's so much easier to talk to doctors about what they can do to fix this problem than it is to actually sit with drug users, right? Not all of them are real nice, but not all of anyone is real nice either, right? I promise I've sat through classes and meetings with doctors that were way worse than days in the exchange. And so I think creating that will and creating that energy and really acknowledging that we need to start thinking outside this box, because what we've been doing is not working, and we are literally seeing, I've been doing this work since 2002. I've never seen anything like this. I have friends who have been doing this work since the 70s and the 80s who lived through the mass death of HIV, who are now living through not only HIV, hepatitis C, and overdose death, all coming together at the same time. It is really, those numbers of overdose deaths, those don't include people dying in Alona's care in the hospital from a heart infection.
Mm-hmm.
We're looking at it as this little specific, more people die from methamphetamines in Oregon than opiates do. Now, granted, some of that is the same because of the way we count death numbers, right? Some of those meth users also were heroin users. But that's a whole conversation about how unreliable death data is. But, these are things that we need to take action towards. And we need people to be brave. We need champions in our community to say that we're done. My heart can't take much more. We need people who are willing to pull together a panel for Public Health Week
to talk about it, to have these conversations and really move past the I'm afraid drug users are going to use in my yard to how do I help keep my community safe?
And I was gonna say, I would add, some of our challenge, I think from the public health perspective, is we have siloed funding, which leads to siloed thinking. And the siloed thinking leads to siloed action, which actually doesn't get us out of our problem. And so we keep going around in this circle, and until somebody, I think, is brave enough to step out of the siloed thinking and the siloed funding, and then we'll get something that's more of a result. And I would have to say, I think the last 2 months, which is hard to only have like real hope the last 2 months, I've started hearing the federal government use the word syndemic, and it sets off my spell check, so it tells me it's not used very often, about the syndemic of infectious disease and overdose and opioids and methamphetamine and drug use. And if we don't talk about them at the same time, and STIs, because we also have a syphilis problem, and our rural syphilis problem is related to drug use. And if we don't start talking about meth in Oregon and we wait till meth gets to Atlanta or the East Coast, there's gonna be a lot of dead people. So that's kind of my
Can you
stay.
define syndemic? Because everyone keeps tossing it around in our little bubble and we know what we're talking about, but in case people don't know what that word means.
So when you were saying, we have this opiate crisis or this opiate epidemic, we have an HIV epidemic, I would say we clearly have a hepatitis C epidemic in Oregon. It's all of these are interrelated, they feed off each other, and we're not gonna get out of one if we don't address the others. And so it kind of feels like, to me, monkeys in a barrel. The second you kind of get out, you're gonna get pulled back down because.
But this panel is reproducing that because you've talked about several different topics. The film you showed is fabulous. The presence of this panel is important. If you want to focus on getting SIFs in Portland, the answer is do dozens of these panels around the city. The Multnomah County Commission is 5 people. 3 of them are women of color, 2 of them are white women. They are susceptible to pressure. The leadership of the Multnomah County Health Department is susceptible to pressure and open to being pressured. We're not Seattle, we're not San Francisco, we're not even Eugene. But we may have an opportunity here if the people who are doing this work can agree to focus on is getting a SIF in Portland something that we think is an important point to rally around. And then the second question I would ask is, has anybody approached hospitals to see whether hospitals on a free basis would offer an empty space as a SIF in Portland? I'm sure their lawyers would go ballistic.
I have to speak judiciously. And I'll just say that I'm speaking for myself and not as a representative of my institution. But I do think that hospitals, especially, and really any place that people encounter the healthcare system has an opportunity to expand its services to our community, which includes people who use drugs, and that in every area of healthcare services, that part of the educational and health promotion that we have the opportunity to engage in includes things like safer injection practices, like talking about people's options as though there's a range, which is true. And just like we provide people with education to inject their insulin more safely, we can do that with I'll say the medicines that people use to stay well. Because especially when we're looking at a chemical dependency, like oftentimes people who have, I'm gonna digress. I wanna focus on your question. Yes, yes I do. I think that we have a number of existing physical structures that could house and provide additional support services which could function as safer consumption spaces.
I would also like to, not get carts before horses on this, right? I think that the work that was done in Seattle and the work that was done in San Francisco, less so in Philadelphia, but it was really about community organizing and really about getting enough people at the table. And I'm excited to see that the table around drug users' health is growing. But I can tell you, it's been taking a long time to build that up and to get the right stakeholders to even pay attention to this as a thing. And so, to get direct to your question, it is still illegal to do. Actually, in Oregon, it is still, syringe exchange is still not legal.
Yeah, but the state legislature has not preempted Multnomah County yet.
No.
And if you get to Multnomah County before it gets preempted, then you get a pass on preemption.
I don't think I know what that word means.
So the way conservatives work in this state is they pass a law at the state level that says the county cannot make a law about something. If the county gets there first and makes a law that says SIFs are legal, then the state cannot take that away.
Okay,
It's grandfathered.
got it. Now I understand what you're
Okay.
saying. I don't know that this, and where are we on time? Okay, I like this and I would like to talk to you about this. Because you obviously, really, you know some stuff that I don't know and I want to know it.
Right.
That's all there is to it. There is a group here locally working on advocacy for safe consumption, Safer Spaces Portland. I will tell you, there are 2 of us and we're volunteers. And we're doing as much as we can. I am on the National Network for Safe Consumption Spaces, which has about representatives from, I think, close to 40 cities nationally that are working on this in various degrees. We meet every year to sit down and really talk about where we're at, and also talk to each other regularly because we're friends. It's a small network. I think that the conversation is just starting. But I also think it's got to start somewhere.
Sorry. I was gonna add, and I think a lot of things that we're seeing are community members educating themselves, like wanting to bring the injection room model. People having forums like this. This is, I think, your 3rd or 4th one.
This is the 3rd time I've screened this film, twice in the last week and a half.
Yeah, so I think doing a lot of community building so that when the idea moves forward, there's not this as big of an avalanche back. And that being said, I don't expect there won't be some pushback for an idea like this.
I like pushback.
Yeah, so
I'm kind of confrontational.
I think they're working on that.
I think just to tag on to what you're saying, we need diversity. We need to be in diverse spaces. We need to be talking about this in as many neighborhoods and communities as possible. We need there to be active users at the table. I think that having a range of drugs and methods of administration present, because it's not just about opioids. I think it's important that we are talking about opioids, and it's real, and people are dying, and that's terrifying, and it's getting worse. And there are all kinds of substances that people are using, and all kinds of people who are using, and I think the more that these conversations can happen with respect to diversity, the more the broader our strategies can be in addressing a very complex issue with so many facets that are affecting people's health and well-being.
So I just want to do a quick time check. I know it's 3:30, so there's plenty more to talk about. So I think if our panelists are willing to stick around and folks want to stay, and if folks on the phone have any questions they want to type in, we can monitor, but it is officially the end of the hour. So if you need to get going,